Honorable panel of experts and the learned audience, very good morning to all. I am Dr. Moni Rani, working as a medical officer in Department of Radiotherapy, Rangpur Medical College Hospital, going to present my research work. That is comparison of outcome of interdigitated versus sequential brachytherapy along with concurrent chemoradiation in locally advanced carcinoma cervix. First introduction. Cervical cancer is the fourth most frequently diagnosed cancer and the fourth leading cause of cancer death in women. Approximately 90% death occurs in low and middle income countries like us. It is the second most common cancer among Bangladeshi women after breast cancer. Now rationally, in locally advanced carcinoma cervix, combination of concurrent chemoradiation with EBRT and brachytherapy is an accepted definite mode of the treatment. Overall treatment time should be ideally 49 days or less, but should not exceed 56 days because overall treatment time has a direct correlation on the treatment outcome. In conventional method, when brachytherapy is started 1 week after completion of EBRT in 3 continuous weekly visits, resulting a lot of dropout of the patients and overall treatment time taken around 9 weeks. But if brachytherapy interdigitated with EBRT, then total duration of treatment can be drastically reduced to approximately 5 weeks. And from radiobiological point of the view, is likely to be more effective, and there is the evidence that this approach is radiobiologically acceptable. So, to find out the efficacy and the treatment of interdigitated brachytherapy versus sequential brachytherapy is the major objective of my study. Now, material and method. It was a quasi-experimental study performed in Department of Radiotherapy in Russian Medical College Hospital from January 2020 to December 2020. Patients with locally advanced squamous cell carcinoma cervix, FIGO stage 2B to stage 4A, visited during the study period in my study population. According to this formula, total 68 patients were included, 34 in each arm, and the sample are taken by purposive sampling technique. Histopathologically proved squamous cell carcinoma in cervix in locally advanced stage, ECOG performance status 2, age range 18 to 70 years, and at least one measurable lesions were included in my study. Patients with previously treated for carcinoma cervix like hysterectomy, radiotherapy, chemotherapy, or suffered from severe concomitant medical illness like the heart disease, diabetes mellitus, uncontrolled hypertension, renal impairment, or pregnant and lactating women were excluded from my study. Treatment planning. Eligible patients were allocated into 2 arms. In arm A were first concurrent chemoradiations with EBRT 50 gray in 25 fractions over 5 weeks with injection cisplatin 40 mg per meter square weekly for 5 weeks given. And here high dose load brachytherapy, that is 7 gray weekly in 3 weeks, started after 30 gray of EBRT and given concurrently with EBRT and chemotherapy on the off day of EBRT and chemotherapy. In arm B were radiotherapy and chemotherapy given in the same manner like the arm A, but here brachytherapy started after 1 week of completions of EBRT and given in 3 continuous weekly visits. Patients were assessed weekly during treatment and 4th weekly after treatment. Treatment response assessed by RECIST criteria and quality of the life assessed by ECOG performance status. Data were analyzed by species version 25, continuous variable analyzed by chi-square and pair t-test, and the categorical variable by chi-square test, and p-value less than 0.05 were considered statistically significant. Now result. Total 68 patients were enrolled, but final analysis was done on 63 patients, 31 from arm A and 32 from arm B. This bar diagram shows the age group distributions of the patients, age range 29 to 64 years, and majority of the patients from 41 to 50 years with mean age 47 years. Now socio-demographical profile of the patient. Majority of the patients were illiterate, housewife, low socioeconomic conditions, and belongs from rural area. Majority of the patient, that is more than 60% from stage 2B and least was stage 4A. Parvaginal discharge, parvaginal bleeding is the major symptom in both group, and also some patient complain pelvic pain, weight loss, anorexia and dysuria, but there is no significant difference in between two groups. Growth presents in 100% patients in both group, parvaginal bleeding and parvaginal discharge found more than 80% cases, and parametrial involvement found more than 90% cases in both group by paraspeculum, parvaginal and bimanual examination. Now the response of the patients after 3 months. 90% patient from arm A and 78% patient from arm B had complete response after 3 months. 100% patient of arm A and 95% patients from arm B from stage 2B had complete response, where 100% patient from arm B had partial response. Now the overall treatment time. Overall treatment time ranged 35 to 42 days in arm A, where 56 to 63 days in arm B. And these results was statistically significant because p-value is less than 0.001. Vaginal toxicity, rectal, bladder and skin toxicity is the major toxicity in the both group, though the percentage is higher in the arm A, but statistically it was not significant. Treatment time beyond 7 to 8 weeks were shown to reduce locoregional control and overall survival found in many researchers. In my study, mean overall treatment time 38 days in arm A and in arm B 59 days. It was found in many researcher findings. Toxicity in my study are slightly higher in interdigited than sequential arm, but it was not statistically significant. Now the conclusion. Overall response was higher in interdigitated arm than sequential arm, but the superiority was not confirmed statistically, and there is then significant reduction of overall treatment time in interdigitated group. A small sample size, non-randomized sampling technique, conventional technique used for radiation planning, single-base center, and the shorter durations are the major limitation of my study. Thank you all for patient hearing.